All right. So, Jill, do you want to present the case for us?
Sure. So this is a 59-year-old female with a past medical history significant for insulin-dependent diabetes, hyperlipidemia, hypertension, OSA, but not on a home CPAP, AFib, and end-stage renal on peritoneal dialysis, who presented today with severe abdominal pain and distension. Should I keep going?
Oh yeah, you can. Yeah, you can say a little bit more.
Okay, yeah. So pain started on Monday. Sudden onset, sharp, diffuse pain while she was sitting up in bed. She laid back down to see if it would subside, but the pain persisted. It was associated with some nausea. She ended up not being able to move much because of that. She noted that it was sharp and diffuse, but non-radiating beyond her abdomen, and her stomach became more and more distended throughout the day. She ended up calling EMS, who took her to Jefferson. She does get dialysis PD daily, and her last session was Monday morning before the pain started. I think that's all I have to say about that. In terms of her meds, just of note, she had a recent hospitalization at Temple for vaginal bleeding. She got a DNC there, and they held her Eliquis that she was on for her AFib at that time and did not restart it. And yeah, so for her meds, she's off the Eliquis now. As I said, she takes Metope. She takes, she has insulin-dependent diabetes. She takes Sensipar. She takes Zyrtec, atorvastatin, and calcium acetate. I think that's it. Social history, she lives with her daughter, who provides essentially all of her care and also manages her PD for her. She has no alcohol, smoking, or IV drug use history. And surgical history, other than her PD catheter placement and her recent vaginal procedures, are not contributory, and her family history is not really significant.
All right. So we gave you guys most of the case this time. But is there any other questions, anything clarifying, anything further that y'all want to know about this case?
How was the pain onset, like, temporally related to the peritoneal dialysis? Like, was it when she was getting it, when it was finished? Like, was it related to that at all?
She gets her PD daily, and the pain was hours later. So not during, and no direct relation.
How long has the Eliquis been held for?
So she was actually discharged from Temple 4 days before presenting to Jefferson's ED. She gets all of her care at Temple usually. The ambulance just happened to take her to Jefferson this time.
Was there any relation to eating? Like, what did she eat, like, a little bit before the pain started?
No, she didn't eat right before. She did have nausea because of the pain, but she really wasn't eating much due to pain after it started.
Also, does she use, like, NSAIDs a lot?
That's a great question. I don't know.
Has she ever had any episodes of infections related to her PD?
Once previously, she said she might have had a belly infection similar to this. She's not sure what treatment she received, and she's not actually sure. She said she thought it was growing something around her catheter about a year or two ago. That was what she told me.
And does this feel like that?
She says this is worse than that.
Did you say that she was discharged from Temple recently for vaginal bleeding?
Yes.
Has she had any like surgical manipulation of the peritoneal dialysis catheter after it was placed?
It was originally placed on her left side, and they changed it to her right side about 1.5 years ago. When I asked why, she said because she thought it was growing something around there. But none since the site was changed. She's not a great historian, if you're getting that vibe.
Any other questions at all? So, what might you want to be looking for the fit? Or we can get vitals real quick. Vital, I always forget about vitals.
Yeah. So she was afebrile. I think she was 96. Her heart rate was in the 80s. Her blood pressure was 80/30. And then after 1 liter of fluids, it went to 108/58.
All right. Now, what kind of things may you be looking on physical exam for this patient?
I mean, just like generally, is she like toxic appearing? Like, does she, how uncomfortable does she appear in the bed? Basically.
Yeah, so she's not diaphoretic. She does look like she's in pain. She was laying in like somewhat of a fetal position, and anytime I try to manipulate her, she winced, but laying down, not moving, she was comfortable.
Does she seem to have fluid in the abdomen? Does she have like fluid wave or anything, or distension?
I didn't appreciate a fluid wave on exam, but she had significant abdominal distension. Of note, she says at baseline, her abdomen is moderately distended, but she said this is beyond her baseline.
Did she have peritoneal signs on abdominal exam?
She was exquisitely tender, and she had guarding whenever I tried to palpate her stomach.
And just going over physical exam signs for like peritonitis, some of them are a bit more accurate than other ones. Actually, one of the best ones that has a pretty good positive and negative light code ratio for peritonitis is actually percussion. So if you guys can see me, it's basically you actually take your finger and almost like you would do on the chest and tap your finger over the patient's abdomen. And if they have exquisite tenderness just with that tapping, that makes it much more likely that they have some sort of cause of peritonitis. Ones that are helpful to rule in, but don't really help rule out peritonitis, the biggest one is rigidity. Did the patient have rigidity? Do you remember?
But she did have tenderness to percussion.
Did have tenderness percussion. So rigidities, so that's a big one. Rigidity is a big one. Rebound can be somewhat helpful, but it's not the best. And the other one that's really good is guarding. So rigidity and guarding are probably the two biggest ones that can help you rule in if you find them. The ones that can help you rule out, is going to be that percussion tenderness. Another one that's actually pretty helpful is having the patient cough. So if you have the patient cough and that doesn't make their abdominal pain worse, it actually makes it a little bit likely. That's called the cough test. And I think those are the kind of two biggest ones. There's also another sign that's used a lot more for chronic abdominal pain. That's called the Carnet. I think it's called the Carnet sign. And this is a sign that you can try to tell whether their abdominal pain is musculoskeletal or it's intra-abdominal. And you actually have the patient kind of like they're laying on their back and you press on their stomach and then you have them sit up so they activate their muscles in their abdominal wall. And if that makes the pain go away, that's kind of concerning because that means that you kind of just blocked your hand and that makes it more likely to be abdominal pain. If the pain gets worse with that, it's more likely to be musculoskeletal. So those are kind of helpful things that I would think about when you approach abdominal pain that can help you with, peritonitis, which could be a sign of acute abdomen, but also, other things. But it sounds like diffuse tenderness, percussion tenderness as well. All right. Oh, why am I writing that down there? All right. Any other questions about the physical exam? All right. We could just, I think, we're going to spend a bit more time here on differential diagnosis and, on treatment. But, I think we should definitely go into differential diagnosis and further testing as well. So what do you guys?
I think there's a question in the chat about physical exam.
Oh, sure. What, can you read it for me? It's hard to get the chat open.
Oh, sure, no problem. Basically, people are just asking if shaking the bed to see if the patient is peritonitic is a normal maneuver.
Oh, I've heard of that one. I haven't. I'm sure it is if they do it. Because they rely so much more on physical exam than I think we do, because we don't see peritonitis and acute abdomen quite as much as they do. I hadn't read about that one specifically, but it's probably pretty similar to the cough exam. Where I think I would guess that it probably is a helpful rule out, but may not be like a helpful rule in kind of thing. But I don't know the specific evidence on that one myself.
I have one more question about the physical exam. Was there any bruising in her flank?
No.
Did anyone do a fast exam?
Nope.
No fast. What would you be concerned about with or what would you be looking for with a fast exam?
I guess just fluid collections, fluid in the abdomen. She had vaginal bleeding. Could there be fluid in the pelvis or something?
Yeah. So what's kind of on your differential right now? Anyone?
I mean, bacterial peritonitis probably secondary to an infection of her Pd catheter.
And what would you kind of want to do to think about that?
I'd probably just start by taking a look at the abdomen. I don't know if doing an ultrasound of the abdomen in that situation to find a pocket to tap would work, but I'd want to tap it.
Sure. Yeah. So absolutely. So pairs, and actually you don't really need to do a pair. You just kind of take it off the catheter, which is nice. So fluid sample. And then they did.
Sorry, one quick question about that. Is there any, if you take it off the catheter, is there any risk of it being contaminated with, I don't know if there's any colonization of the catheter that you would get that similar to a chronic Foley?
That specific question, I'm not sure about, but it sounds like there was actually a debate about that.
Yeah, so we asked nephrology that, and actually between two different fellows and the attending, there was debate over whether they could use just the fluid sample or if they needed a fresh tap. And to be honest with you, I'm not sure what they settled on, because as of yesterday afternoon, they were still going back and forth.
Gotcha. All right, thanks.
There was a CT though, so they used kind of the CT. There wasn't much findings on it. Does anyone want to tell me what they see here? Any findings?
And the spleen looks pretty big. What is that? Is that her kidney pushed forward, or?
I think this is stomach right here.
Okay. got it. That makes more sense. Like wondering, yeah.
I think right around the liver, Grodsky.
Oh, I mean, it's pretty large for sure. And kind of on the, oh, okay, yeah, you're highlighting it for me. Is that, I mean, is that like the capsule? Like it's, I don't know what that color, like
it's
if
just
it's
fluid
or,
yeah, it's fluid. Yeah, I just put this one in because there was fluid in the abdomen. I mean, peritoneal dialysis, you're going to expect that, but we were kind of considering that, and I think that was really the only finding that they had on the CT scan. I think maybe they said there was some signs that maybe the fluid could be infected, but it was kind of like back and forth. So I think it was like fluid cannot rule out infection, like the typical, correlate clinically, which is fair. That's what we're here for. All right. So we did the fluid sampling, and what did we?
13,000 white blood cells with 91% neutrophils. And I forget the amount of, I think it was like 10,000 RBCs.
Yeah. Okay. All right. So, I think you guys got to it pretty quickly, and I didn't want to make this too much of a differential diagnosis, but does anyone want to just interpret this for me? Does anyone know the specific cutoff for bacterial peritonitis from a PD catheter? Because I think it's kind of interesting because there's a lot of pathophys actually involved in the cutoff. And honestly, I didn't know until last night when I looked it up. So it's not something that everyone should know. All right, so the specific cutoff is actually just 50% neutrophils. And you don't really want to look too much, or if it still has a low white count, that doesn't actually matter that much. And the reason why is that doesn't really matter that much. Does anyone kind of know how you do peritoneal dialysis? Does anyone know how it's done or kind of the pathophysiology behind it? If anyone had a patient with this before? I know it's kind of a long question, so I understand if no one wants to answer.
I mean, it's essentially kind of like you use the, sorry, it's a little loud in my end, but essentially you're using the mesentery as the dialysis membrane. So you instill, if I'm remembering correctly, you put a hypertonic glucose, like sugar solution in. That the glucose, the hypertonic glucose draws fluid out, and with that you get solute drag, and then the PD, effectively you cycle the fluid out back into the PD, and eventually the glucose gets broken down, getting returned to so it gets effectively reabsorbed by the mesentery.
Yeah,
I think.
So mesentery can be, I think I know exactly what you're going for. So it's the peritoneum that actually is the membrane that you use for diffusion. But you're exactly right. You actually infuse glucose into the peritoneum. A lot of times you let it sit there for a long time, and then you just have really passive diffusion of molecules into the more hypertonic fluid within the peritoneum. So the patient's creatinine, the patient's potassium, not really, smaller molecules kind of diffuse out of the body through the peritoneum into that fluid. And then that fluid is then sucked out again and discarded. So the fact that they suck this fluid out and then discard it makes it so that the white count is actually being low does not rule out peritonitis, because they could have just had their fluid taken out and you actually got rid of like all of those neutrophils. So the major cutoff is 50% neutrophils. And the obviously thing that can really help you too is if you take a sample and you have cloudy fluid. I don't know if it was cloudy in this case, but if you have cloudy fluid in the peritoneum, you pretty much at that point are relatively sure that the patient has peritonitis secondary to a PD catheter. So does anyone, I'll make this maybe a 50% and I'll look at you guys, because this is a tough question too. Let me bring you all up. So, oh, no one, where'd all the videos go? No one has their video on anymore. I don't even have my video on. So maybe we'll just put this in the chat, or you can bring it out loud. Who thinks that you do, in this case, you would do the antibiotics IV, or who thinks you would do them intraperitoneal? If anyone wants to answer out loud, that's good, or throw in the chat. I can look at the chat too. And guesses are acceptable because this is a hard question. All right, we got some intraperitoneal.
I have seen intraperitoneal antibiotics before. I don't know like if there's some situations where you do IV over that and some where you don't, but I know you can do intraperitoneal antibiotics for this.
Yeah, and that's absolutely true. So the one time that I was reading about this, so let me just put this out here for you all. Diagnosis, 50%. So treatment is really going to be intraperitoneal, unless patient's septic. So, you know, if they're septic, you may think that they have bacteremia and you may need something that's systemic. And if they're not septic, then, you know, most of these infections are basically right in the peritoneum. So they're pretty shallow and you can actually treat them with like an intraperitoneal antibiotic. I think in this case, it was intraperitoneal, but there was discussion, right? Mm-hmm. So what were they kind of discussing about whether intraperitoneal versus systemic? What was their, did you know what their thought process was of renal?
To be honest with you, when I called nephrology, they just said, please don't do anything until I talk to my attending.
Okay.
But I know that the emergency room gave 1 gram ceftriaxone IV.
Oh, okay.
Yeah.
And maybe they're worried about the low blood pressure, I'm guessing. All right, and then what do you think would be the correct, what kind of intraperitoneal antibiotics do you think you would use in this case? Or single or more than one? And there, we got some single. We got some ceftriaxone. All right. We got a couple responses here. And I think this is a difficult question. I think you probably would only. All right, we got 3 different answers, so I'll go through them because they're all a little bit the same, a little bit different. So I think just going over why do these patients get an infection? So actually one of the major reasons they get an infection is called a touch infection. And it kind of is exactly what it sounds like. The patient is actually when they're removing things like the dialysis solution, they're touching their fingers to like ports that go into the peritoneal catheter. And this can actually create a ascending infection that basically goes into their abdomen. If they're touching it, this is from their skin, so what type of bug in general do you think you would need to cover for this reason for infection? Exactly. So really gram positives. And I think there was, you know, a discussion in this case, do we need to cover for MRSA? I mean, I think this patient was just hospitalized. So I think you would need to, and reading on at least up to date last night, you know, you really want to cover for gram-positive. And I was reading that this is done by intraperitoneal vancomycin, which is good. It'll cover MRSA, it'll cover strep. You know, it may not cover VRE, but that's, you know, I don't think you need to cover that empirically. So gram-positive, actually, about 50% of all these infections are gram-positive, which is weird because you think it's going to be gram-negative, it's in the abdomen, but because most of the infection is from outside of the abdomen, it's from touching and skin flora. It can also be from actually the exit or the entrance of the PD catheter. So like a catheter-related infection. So it can be due to the skin on the outside. It can also be due from like contamination on the inside. So you also do need to cover gram-negative. But these are really this is really about 20% of all infections. 30% you don't find a bug. So 20% of infections are gram-negative. And the one that I was seeing that was, I think, used here the most is going to be intraperitoneal cefepime. But I also saw, you know, you can use, and you do want to cover Pseudomonas in cases. I mean, these patients are kind of at risk for hospital-acquired infection most of the time. They have ESRD, they've been in the hospital before. So it sounds like empirically you cover with intraperitoneal cefepime. You can also do aminoglycosides, or you can also do aztreonam, like intraperitoneal aztreonam. So I was reading about this so empiric antifungal prophylaxis, and it sounds like you do empiric, if they're getting antibiotics greater than 3 days, this is what I was reading, you do antifungal prophylaxis. Now, the reason for this is not that you think that they're PD catheter associated peritonitis is from the Canada. You actually prophylax for Canada because they're getting indwelling antibiotics, and it's actually the indwelling antibiotics in their peritoneum that increases the risk for antifungal. And that is why if they're getting, I read getting greater than 3 days, they do an antifungal prophylaxis. I don't know if they wrote about that at all. Maybe it was a little bit too early on for them to say anything about it.
I asked Heifer about it when I talked to, because I was wondering if just the glucose load would create more of an environment for fungus.
So I was reading it, it's a very small minority of cases that the peritonitis is due to fungal, but then you put them at risk for a fungal infection with subsequent treatment, which is kind of crazy.
They did not comment on giving.
Yeah. And maybe they were waiting a little bit to see what happened, and then if they had to treat for a longer period of time, that they would have to consider antifungal. So I think that's what happened with this case. We have a good amount of time left, so I think maybe just going over some stuff with dialysis, because I remember it was always kind of difficult. I understood dialysis a little bit as a resident, but I feel like I didn't have a very, very full picture on it and how it actually worked. So we kind of went over how Pd dialysis works, right? And that's kind of what happens in this case. You know, it's the peritoneal membrane right here. You infuse a bunch of glucose, you know, into their abdomen here. And that glucose basically creates that membrane diffusion coefficient that drags water molecules, that drags smaller electrolytes, right? So, you know, things that are smaller are going to be able to diffuse better through the peritoneal membrane, but things like phosphorus, you know, which is big, it's PO4 2+ or something, that's too big and it can't actually get through there. So that doesn't diffuse and it doesn't get lost. So you infuse this into here, you have that, you know, diffusion from the peritoneal membrane from the body into the dialysis fluid, and then, you know, you suck it out and you discard it. So how does hemodialysis work? And I think most of the patients that we kind of see are on, you know, hemodialysis, though PD is pretty common in other countries. So the way that this works is, I think I have a picture. So you kind of have the blood coming from the artery. So here's the artery. Blood kind of goes into the catheter machines, and then it kind of goes into the part that's the artificial kidney. And this is is kind of what's going on in the artificial kidney part. So the patient has a dialysate that, we create, and, we actually make with certain amount of potassium, calcium, sodium based on the patient's own labs. The blood kind of goes in, and there's basically this counter current diffusion. So the dialysate is moving this way and the blood is moving that way. And kind of what happens, there's a passive diffusion gradient within the dialysis machine that allows small molecules, once again, so things like K, things like sodium, things like calcium, but not phosphorus, because phosphorus is too big, can't get across. So not phosphorus, to basically diffuse down their concentration gradient into the dialysate. And the farther that it goes down, there's this kind of this countercurrent diffusion in which, the dialysate goes this way and the blood goes that way. So the further along it goes, the more they become equal. And by the end, that the blood should be, relatively lower in creatinine, relatively lower in potassium if they're hyperkalemic, and relatively lower in, sorry, not creatinine, but relatively lower in urea. And that's the things that you're trying to remove. That blood then goes back into the body. And you kind of create your dialysate with different levels of calcium, potassium, sodium, based on what the patient's own labs are, to make sure that, after dialysis, the patient doesn't have, high potassium or subsequently low potassium and things like that. So what are some complications you guys remember about hemodialysis? What's some things you worry about when your patient goes down to hemodialysis in the hospital?
Hypotension.
Yeah, exactly. Hypotension, and that's, really due to pretty quick water loss. So, the water's going to go down the concentration gradient as well. It's going to go into the dialysate. And this can happen a little bit too quickly. And the thing you got to remember is patients on dialysis have such limited reserve. This patient, we didn't know, we didn't present, but they actually end up having like really severe pulmonary hypertension, which you can get from long-term dialysis. It could have been from the patient's obstructive sleep apnea as well. But a lot of patients have such poor reserve that they can't, especially after a long period of time, they can't handle these really bad fluid shifts. And, if you do a dialysate session, especially if you're trying to do it quickly, they can get decreased blood pressure. Anything else y'all remember?
Dialysis disequilibrium.
Disequilibrium, yeah, and disequilibrium is thought to be actually due to basically pretty big shifts in glucose. So usually there's no glucose in dialysate. There's like none at all. So, but there is glucose in your blood. So a lot of times that glucose gets lost into the dialysate, and that can actually cause that disequilibrium syndrome, in which the patient feels very off, may not be able to walk, things like it almost seems pretty similar to hypoglycemia. So sometimes they do put dextrose in the dialysate. I don't know when or the indications, but that's another thing that they really want to think about. So here's a good question. What do we think for peritoneal dialysis versus hemodialysis? Who thinks that, which one has the better mortality or like survival? Or do they have about the same?
I think PD has better quality of life and survival.
So yes, but there is some nuances to this. So kind of looking at, and I find this really interesting, and this is kind of from the Curbsiders when they had Kidney Boy on, which I just love that guy. I love that name. But for survival for PD, so PD is here versus HD. You're absolutely right with quality of life. That's a huge thing. People have a much better quality of life with PD. But the survival is actually in less than 1.5 years. It's better with PD. And then usually around greater than 1.5, better with HD. And the reason why is kind of interesting. It's that, so peritoneal dialysis, I mean, if you kind of look at it and think about it, it just seems a little bit more natural, and it's also a bit of a slower process. They're putting this glucose in a lot of times, a few times a day. It's dwelling there for a long period of time. They're not having these very quick fluid shifts. And what that does, it actually PD over a short period of time, relatively, so maintains the patient's residual renal function a little bit better. So, and that relative maintenance of renal function in about over that 1.5 years can actually increase their survival. And kind of to know if the patient has some renal function less. This is also from the Curbsiders episode on dialysis. If they can make greater than a can of soda of urine a day, they probably have some small amount of residual renal function less. So that is kind of the why that PD can be helpful early on, but it may not be too helpful over a long period of time, especially once you get past 2 years to 5 years. It sounds like hemodialysis, really once they lose all that renal function, I would say that hemodialysis is the way to go. So certain people can't get PD. Does anyone know relative reasons not to have peritoneal dialysis? And I think I kind of said one. If they have like no GFR, I don't know if it's worth it, but I'm not a nephrologist either.
I think people who are like unable to do it at home, like it's definitely a lot more work on their end. I feel like is a big reason that a lot of people don't do it.
Yeah, I think that's one of the huge ones that socially, or if they don't have any social support, or they can't manipulate the catheter themselves, or that they're not able to like follow directions well. That's definitely one. I can't do it personally. I don't know. But yeah, that's absolutely one. So if they just like can't, they're not gonna be able to do it. They don't have the support at home, or they don't have a great functional status, or maybe they don't, maybe they have mild mental disability. You really can't have them do the PD. Any other reasons? I mean, think about PD. You're putting it into their abdomen, right? Like
Cirrhosis.
Cirrhosis for sure. I didn't read that one specifically, but that definitely makes sense.
Does like multiple abdominal surgeries have an impact on your ability to do it?
Exactly. Yeah. So if someone had surgeries, they have adhesions in there, they're really not going to do well with the PD. And the last one is obesity. Like obesity is another one. I'm not exactly sure why. I don't know if it's technically difficult or it's because they have, PD doesn't get off as much, really doesn't get off, like doesn't diffuse as much substances as HD is able to do. So if someone has no residual renal function, or if they have, high amounts of blood with obesity, it just may not be as helpful. But I'm not sure if obesity is actually, if it's a technical thing, or it's just because they need a higher GFR, higher artificial GFR. All right, cool. I guess we're kind of out of time. But I was going to go into some other stuff, but that's okay. I think we got through a lot today. Any sum up of the case or anything? I don't know whatever happened to the patient.
I actually have a question for you.
Okay.
So
I might not know it because this is about the extent of my knowledge on the subject.
the ED did 1 gram of ceftriaxone.
Okay.
Which
And that was IV, right?
IV.
Yeah.
And I was wondering why 1 gram. I think they were thinking more along the lines of SBP, and why 1 gram in that case and not 2. And is it always cefepime? Are we always covering for Pseudomonas?
For this, so I think from what I was reading, you always cover for Pseudomonas, and that could be aminoglycosides, cefepime, estrianam. The 1 versus 2 grams, I'm not exactly sure. The one thing I actually didn't cover and which I wanted to cover here, is that just like SBP, this should be monomicrobial, right? So this will either be 1 gram positive or 1 gram negative. If you see a polymicrobial infection in one of these patients, you really want to think about, do they have some sort of perforation, and do they have, and you're really going to want to, if you see a polymicrobial infection in one of these patients, you need to get imaging, and you need to call surgery as well, because you need to really be considered. And that's really anytime you see a polymicrobial infection and you're thinking about either SBP or catheter-associated peritonitis, start thinking about secondary peritonitis and start thinking about some sort of perforation, whether that was due to ischemia or like diverticulitis or something like that. For the 1 versus 2 grams, though, I don't really know. I mean, I think if you're treating, so I guess if looking back, you're only supposed to do IV if the patient's septic, and if you're treating septic sepsis, then I would definitely do a higher dose of septic. So they probably, but I don't know what their thought process was. But I don't think that was right.
The one other thing that we had questions about that you had answered this morning for us, but would be helpful for them to know, I think, would be like catheter exchange.
Oh, yes.
That was something we were not sure about.
And my knowledge only goes to what I read on Really Up to Date last night, but and I had one patient with this, and that's kind of why I learned just maybe the generals of peritoneal catheter. So catheter exchange, what I was reading is only if I heard very severe, like septic, refractory. So if you're treating it, it's not getting better. Certain bugs I saw, so if they do have, if they are the small minority that has a fungal peritonitis, if they have like TB peritonitis, I did see in one place, I'm going to put this in a question mark, Pseudomonas. So that was kind of the reason why I saw for catheter exchange. And mostly like if it's like severe or refractory, or if it's like a weird bug, then you would do a catheter exchange. But it sounds like, I guess the takeaway is that you just don't always do it. It's not like they have it, let's take their catheter and put it back in. And maybe it's due to how difficult that actually is, and the fact that they would probably have to get a catheter in their neck and go on HD for that amount of time while you wait for the PD catheter to mature, the new one to mature, which takes about 2 to 4 weeks. So I don't know, but it sounds like it's you don't always do it, but you do it in certain cases, especially if it's severe or refractory or weird bug. All right.
Also, apparently ID doesn't run the show. I don't know if you guys consulted ID, but I had a couple peritoneal dialysis infections, and apparently nephro just runs the show. The ID attending actually told me that he's only like ever dealt with like 2 of them, and he didn't really know what to do.
That was my experience as well when I had a patient that had this too. Yeah, the renal kind of runs it.
Running the show is a loose
term. I haven't said running the show is a loose term.
I guess I shouldn't be as spicy, but it's hour 13. So.
All right, y'all. I think I'll let everybody go, but thanks for tuning in, and thank you for our TMARs for doing this. And MAI.